Hi, this is Dr. Thompson. Just want to welcome you tonight to Asthma Bootcamp. I just wanted to take a few minutes at the beginning of this just to welcome you and to encourage you that we're very glad you're here, and we hope that you take time to learn all the things that we have set up for you in the stations. I just want to talk for a second about why it is that it's so important for us to become excellent at asthma and how we treat it and how we educate about it. The first thing is asthma affects our kids. So we live in West Texas, and asthma is a huge problem in this area. And we know that it affects the kids that come in. It affects their school performance. It affects the way that they're able to play in sports. And then, most importantly, it affects them psychosocially. It affects the way that they feel about themselves, how they're able to interact with their friends. And just everyday life is really affected by this disease. We know that this disease is very prevalent in the region that we live in. Also, asthma in the new world of medicine is going to affect our hospital. And so what we know is that asthma accounts for a tremendous amount of dollars that we utilize every year in the medical care industry. And our better treatment and better education about asthma is going to cut those dollars. And the bottom line is that our reimbursement is going to be tied to how it is that we treat asthma. One of the new things that we've taken on at Covenant Hospital is a core measure in asthma. And part of that core measure is how we treat asthma. Other things are how we educate about asthma. Parts about how it is that we learn how to educate our kids to take care of their asthma at home. Tonight you guys are going to go through a bunch of different stations that are going to teach you a lot about this stuff. And I encourage you just to take your time and really soak in the things that are happening in these stations so that we can all do better about the way that it is that we treat asthma. I'm going to spend just a few minutes just kind of reviewing with you some of the components of asthma. This picture right here is just showing you the difference between a normal airway and an airway in an asthmatic. And really the two things that I want to talk to you about tonight are there's really two components that we see with asthma. The first is inflammation, and so what you see in this picture is just a really edematous airway that has reduced diameter, so you have reduced airflow. And this is secondary to the inflammation. And then the second component is what we call bronchoconstriction. There's smooth muscle that surrounds airways, and what we know about these airways in kids with asthmatics is that those airways are very hyper-responsive. And so the bronchoconstriction happens as a result of the fact that those airways are very hypersensitive to certain triggers. You can see that when both of those happen, the thing that happens is that the diameter of the airway is narrowed. The narrowing of this airway as air goes through it is what causes kids to have a hard time breathing when this is happening. There's a third component that can happen where when all of this happens, we also have increased mucus production. So when you add together an airway that gets smaller quicker and with other triggers than normal, when you have airways that are lined with inflammation, and when you have a lot of mucus production, what this allows you to do is not breathe very well. What happens is the air moves into the lungs. It's then caught behind this area that's so inflamed, and it becomes obstructive. And so you get a lot of air trapping behind this. And so kids have a hard time breathing out all of the CO2 that they should be exhaling. Their airways become hyperinflated. Obviously, you can see that it's hard. The more inflammation and the more bronchoconstriction that happens, it's hard for air to get both in and out. Our therapies that we have for asthma are going to be directed at both of these things. And so our rescue medications are going to go for that bronchoconstriction component, which are going to help those airways open up. And our controller medications are going to be geared towards that inflammatory side that cut down on all of that edema and inflammation that's in the airways. So these are really the components of asthma that make it sometimes difficult for us to treat. Just to kind of review just some signs and symptoms of asthma, obviously the most common that we see is wheezing. Wheezing is typically an expiratory noise that we hear whenever patients are trying to breathe out against those closed off airways. We hear the sound of wheezing. What we know about wheezing is when it begins to happen both inspiratory and expiratory, that obstruction is getting worse. And then actually the third thing that we see is whenever we quit hearing sounds altogether. So the obstruction has gotten so bad that we actually don't hear any sounds. This is probably the most worrisome time when you should begin to worry the most about your patient, is when you've actually lost the ability to hear the air sounds through their lungs. We talked about a prolonged expiratory phase. That just means in the normal course of breathing in and out that you have a longer time that you try to breathe out. And this is secondary to the fact that they have all that air trapping. So they're trying really hard. Their body's trying to get rid of all of that CO2 that they've built up in their lungs. In children, it's important to know that we have cough variants, and so a lot of kids will come in, and even more than wheezing and some of these prolonged expiratory phases, that they'll have a lot of cough. A lot of these kids will complain of cough at night, even when they're not sick, and they'll have an abundance of coughing when we come in to treat them for an exacerbation. Shortness of breath is an important thing for you to watch for in your patients. One of the things that I like to get patients to do is to try to talk to me, and talk to me in complete sentences. When I hear that they're short of breath and they can only, one word and then they're breathing in and out, this is a sign to me that the obstruction is getting worse and that we need to step up our therapy. Obviously, tachypnea, so when they're breathing fast, this happens whenever they're attempting to blow off some of that CO2 that they've built up, as well as continue to keep their oxygen saturations. And then one of the things that begins to happen as we have more obstruction is that their oxygen saturations begin to fall. And this is when they require oxygen. And obviously the constellation of these symptoms is the thing that's the most concerning. So when you go from wheezing to biphasic wheezing to no sounds, and then you have a kid who can't hardly speak in complete sentences, who's breathing very fast, and he's requiring oxygen, this is a kid that we need to worry about, and we need to worry about stepping up our therapy. One of the most important things I always talk about with signs and symptoms of asthma is it's really important to hit kids early. So we don't want to wait until kids have gotten into trouble. We want to hit them hard early. And so, putting kids in and putting them on every 4 to 6 hour albuterol in the hospital, I really think that, they need to be spaced to this. So when we put them in, I like to hit them, hard early with the bronchodilators. We have to give some time for our steroids to start working. And so when you start seeing any of these signs and symptoms, this is a chance that you need to take to call whoever physician is on and allow them to know that the signs and symptoms that you're seeing are getting worse. Real quick, I just wanted to review a chest x-ray of a child here with asthma. And what you're going to notice here is in a normal chest x-ray, you expect to see about 8 or 9 ribs expansion in a normal inspiratory film. What you see in this film is that you actually have 10 to 11 ribs. And so this is due to that hyperexpansion. So everything that we've learned about why asthma does what it does is shown in this x-ray. You also see those diaphragms are really flat, and this is secondary to the air trapping. There's also a lot of really black areas, which is just consistent with all of that air trapping. You're also going to learn tonight about some triggers of asthma. We know that viruses are one of the most notorious triggers in kids. We're going to learn about things like smoke and allergens and exercise and weather, and how it is that we need to help families look out for the thing that actually is triggering their child's asthma. We're going to talk about therapies, and we kind of talked about how the therapies are based on what's happening with the asthma. So we have bronchodilators that serve for that component of airway hyperresponsiveness. We have anti-inflammatories, so steroids. They're going to kind of shut down the immune system in the sense that it's going to cause all of the edema and inflammation to go down. We're going to talk about big gun steroids that we use whenever kids are having acute exacerbations, and controller inhaled corticosteroid and anti-inflammatory medications that are going to be used to control them in between their asthma exacerbations. Good use of controller medication is the thing that's going to turn around all of our kids with asthma. If we get them on good anti-inflammatory controller medications, what we see is we have kids that have less severe asthma exacerbations. We see kids that don't actually have to come into the hospital anymore for their exacerbations. And one of the clues to us that we're not adequately treating their asthma or having them on high enough doses of these anti-inflammatories is when they're having frequent exacerbations. Obviously, kids I worry about much more are kids that are landing themselves in the intermediate care unit or the ICU as a result of their exacerbations. And then you're also going to learn about a few adjunct therapies, so things that we have to do whenever we have to kind of step up the game, things like magnesium and terbutaline, and some things that we use in more emergent settings to try to get a hold of the exacerbation. And really the thing that we're going to talk about a lot tonight is strategies for success. So one of the things we want to teach you guys how to do very well is fill out the asthma action plan. We want families to go home learning what kind of things to look for how to control their asthma. We want to do a lot of education with the family where they understand why asthma does what it does, what the medications do and how they're working. We want to watch kids take medications so that we can identify if they have bad techniques. Medications are only as good as the technique that's used to take them. So if you have a kid who can't take inhaler, or they're too young to be on Advair and all the medication's just getting on their tongue, we might as well, not have them on the medications for all the good that it's doing them. So, watching kids take medications, respiratory, you guys completely save us a lot of times where we have you guys come in and watch kids take medications, realize that they're not able to take the medications that we're on. So this is an important piece for us to figure out if we're actually getting those controller medications to them. And then we talked about if we need to add more medications. So doing a lot of history taking with the families and making sure that we need to, we don't need to up their medications so that we have them on the most appropriate steroids and bronchodilators and things like this. So I just want to, again, thank you guys so much for coming. We want to continue to talk with you about asthma. We want you to continue to learn all about asthma. I really feel like if we can tackle this and we can really become excellent at all of the things that we've talked about, both understanding and doing all of the plans and the education, this is what's driving the core measure for our hospital, is we want to become excellent at this because we know that it's going to change how kids do in our region. And again, so thank you guys so much for being here. Rachel, thank you so much for putting it on, and let's continue to move forward in treating asthma better. Thank you guys.